Yeah, we are live.
Good evening, everyone. I am Dr. Sanket Nivale, representing Medical Affairs at Wockhardt, and today we are all gathered here for the L20 Summit, a summit where time-tested legends, along with the newer researched antibiotic in type 2 diabetes mellitus, would be discussed at length during the meeting. The flow of the meeting goes very simply. We'll start with... Good evening, everyone. I am Dr. Sanket Nivale, representing Medical Affairs at Wockhardt, and today we are all gathered here for the L20 Summit, a summit where time-tested legends, along with the newer researched antibiotic in type 2 diabetes mellitus, would be discussed at length during the meeting. The flow of the meeting goes very simply. We'll start with... Good evening, everyone. I am Dr. Sanket Nivale, representing Medical Affairs at Wockhardt. We are all gathered here for the L20.
Dr. Vivekanand, I think you'll have to put your other device on mute.
Time-tested legends, along with the new...
I need to go on mute?
The device you have to put that on mute. I think there are two devices on right now. Yeah, now it's better.
Okay. Yeah. All right, I'll start again. So, yeah. So good evening, everyone. I am Dr. Sanket Nivale, representing Medical Affairs at Wockhardt, and today we are all gathered here for the L20 Summit, where the time-tested legends with Vosulin as our recombinant human insulin and MROC as our levonadifloxacin would be discussed in the management of diabetes mellitus and the infections around it. So with that, I would now hand it over to my colleague, Dr. Alpa, for the introductions. Over to you, Dr. Alpa.
Thank you, sir. Thank you all. I welcome everybody on behalf of Wockhardt. So it's a privilege to introduce our chairperson and the speakers for today's event. First, I would like to share the screen. As you can see, these are our expert panel for today's event. I'll just share screen. For today's scientific agenda, as Sir has said, we'll be first having or focusing on the glycemic management, and the next session will be on the antibiotic in the DFI. So for today's first session, our chairperson is a name which we already know about him, Dr. K.K. Parikh. He's a chairman and a senior consultant in S.N. Parikh Memorial Hospital in Kota, Rajasthan. He has been elected as a president in the Indian Association of Clinical Medicine. He has been a chairman in the National Conference of Association of Physicians of India, that is EPICON in 2021, and also organizing chairperson in the RSSDI 2019. He has been a founder, president for the Research Society of Study of Diabetes in India and Rajasthan chapter. He's been a part of various national and the international conferences, and we know already his name. After this, I will again try to introduce our speaker for today's first session, Dr. Mohammad Nisar Chemban. He is working as a consultant physician in DMS Hospital Intensive Care General Medicine Diabetes Clinic. He has done his graduation course in diabetes management from UK. He has a hands-on training in the advanced mechanical ventilation and endotracheal intubation. He has done research study to predict presence of esophageal varices in platelet count to spleen diameter ratio and many more. He has presented many posters. One of them is on infective endocarditis. He has a good knowledge of clinical practice and protocol in medicine. With this, I will first ask Dr. K.K. Parikh to give a context setting or the overview for the glycemic management. So over to you, Dr. K.K. Parikh,
sir. Thank you, Alpa. Let me first extend my sincere thanks to Wockhardt for giving me this opportunity to be a part of this very important webinar on diabetic management. We at the outset, I also welcome our delegates who are attending today's webinar and my co-chairperson, Mr. Vivekanand, and the two other speakers. So it's really a great pleasure. We all know that diabetes is a chronic metabolic disorder and responsible for increased morbidity and mortality due to micro and macrovascular complication. And we know that inadequate glycemic control lead to many complications responsible for increased mortality and morbidity and increased cost of healthcare. Glycemic control is the optimal blood sugar control in a diabetic patient, and one has to identify to look for the factors which can increase the blood glucose level to prevent and control the complications. Prevalence of poor glycemic control with so many studies is very high, almost between 45% to 93% among many studies done. And for the poor control of, we can look for personal or body related, then clinical, then medication related, environmental and behavioral factors are also very important. And HbA1c is the gold standard for knowing the glycemic control besides fasting and postprandial blood sugar level. And today we all know that CGM is one of the best for the knowing about the glycemic control. The good control according to the ADA is HbA1c is 7%, but American College of Endocrinology and IDF, it says 6.5%, and blood sugar level between 70 to 130 fasting with ADA, and much less, even below 100 milligram of blood sugar level with IDF and American College of Endocrinology. So it is very important. Many good medicines have come in the last 1 decade that for the glycemic control and blood sugar level control. They not only control blood glucose level, but they also take care of our cardiovascular problems, renal problems, and other micro and macrovascular complications. And I can say that it is a revolutionary change in last 1 decade after insulin, which came 100 years before. But these 2 or 3 molecules which have recently come have changed completely, revolutionized the glycemic management of a patient. But still, the insulin is the base therapy for type 1 diabetes, for type 1-2 diabetes who are not controlled with oral medications, and especially the diabetes in pregnancy when we use insulin. So there are so many devices which have also come and so many different types of insulin, long-acting, ultra-long-acting, short-acting, and so many. Now we have got a lot of range of insulin also. So we have got a very good speaker, learned speaker, Mr. Nisar, who will be talking about the role of insulin in the glycemic management of a diabetic patient. So I think he can tell us how we can have better glycemic control with insulin. So over to Mr. Nisar. He has already been introduced by Alpa Singh. Dr. Nisar. Mohammed Nisar.
Yes, sir. Yes, sir.
Should I start sharing the screen?
Thank you.
Yes. Thank you so much, sir.
I'll just start sharing the screen.
All right. I'll directly go to the case study. This is just a case of a simple case of a patient who has been controlled with a glargine insulin. So I'll start with the history. My patient was a 60-year-old female. She's an Asian female. She weighed about 72 kg. Her height was 160 centimeter and her BMI was 28. She was diagnosed with type 2 DM in 2014. In fact, she was on irregular follow-up. She presented in my OPD on February 2020. Her presenting FBG was 425 milligram per deciliter with an HbA1c of 12.5, and her creatinine was 1.5. Her total cholesterol was 289 with an LDL of 186 and HDL of 40. Her triglycerides was 423. Her microalbumin was 980 milligram per deciliter. Next slide, please. And her positive, there was no, previous slide, please. There is no history of cardiovascular disease, thyroid dysfunction, or dyslipidemia. And there is no history of taking parenteral or oral steroids prior to presentation. She doesn't give any history of addictions. She was hemodynamically stable at the time of presentation. There was no signs of volume overload, or we had ruled out even a systemic or local infection at the time of presentation. There was no evidence of ketoacidosis as well. She was treated elsewhere with glipizide and metformin. And in fact, she was again a defaulter. She was not on regular medication. Her SMBG, which she recorded in between, was between 250 to 360 milligram per deciliter. Next slide, please. She was hospitalized and she was admitted in medical ward for close observation. She was started on bolus aspart, and by next day she attained euglycemic state. Next. We had planned discharge with injection glargine 22 units at 8 p.m. With 0.3 units per kg per day. She was added on with an OAD, glimepiride plus metformin, and a statin was added. She was advised intensive diet and exercise as well. Next slide, please. She was reviewed on March 2020, and her SMBG fasting was 68 to 130 milligram per deciliter. Her postprandial was 140 to 180 milligram per deciliter, with one episode of hypoglycemia, which was recorded was 60 milligram per deciliter. Her weight improved to 69 kg. Her BMI was 26 by then, 26.9 by then. Her glargine dose was reduced to 20 units at 8 p.m. Already I had switched to sitagliptin plus metformin combination. Diet and exercise was continued with slight intensification. Next slide, please. And the next visit was on May. During that period, her SMBG was 80 to 140 milligram per deciliter, with the PP values 130 in between 130 to 170 milligram per deciliter. She just had one episode of hypoglycemia, which she attributed to skipping a meal at noon. She weighed around 66 kg by then, at reduced BMI reduced to 25.7. We had continued same dose of glargine and OAD. Next, please. We continued, she was being continuing the same dose of glargine and OAD. She had regular, and her last visit at my OPD was on November 2023. November 2022. And her findings were, her BMI improved, albuminuria even improved to 360 milligram per deciliter, and last creatinine was 1.2. Her SMBG fasting was between 80 to 130. And PP was 130 to 160 with an A1C of 7.2. From comparing to the previous A1C, she had improved very much by this time. Had very few episodes of hypoglycemia. Next slide, please. So for a discussion, I was just concentrating on a basal insulin therapy. So basal insulin therapy may be a slower method of achieving remission compared to an intensive insulin regimen. In this case, basal insulin was maintained throughout with fair SMBG, and basal insulin dose of 0.2 to 0.3 units per kg per day showed fair glycemic status actually. It provides convenient outpatient therapeutic option at a reasonable cost, with diet modification and exercise contributed to a better result. She had no potential hypoglycemic spells, and with single dose regimen, her compliance was being managed. There are data now to support early initiation of insulin to achieve durable glycemic control. So with this case, I just wanted to focus on an insulin therapy, that too a basal insulin therapy, which we had followed up with so much intensification so that the patient is now having a good glycemic status. Next slide. Thank you so much.
So we can discuss on this case. Dr. Parikh, you may lead this discussion, sir.
Yes.
I would request Dr. Vivekanand sir to join in the discussion.
I think
Dr.
sir can
Sanjay,
now try to put his camera on. I've been informed he is connected to Wi-Fi now, so I think network will be better.
Dr. Parikh, over to you, sir.
Yes, sir. Thank you. Now it's a good case for discussion because his glycemic control was very bad. His fasting values were very high initially. So it was very important to use insulin at the first time. But since patient has got microalbuminuria and EGFR, I do not know how much was the EGFR. So can't we add this SGLT2 inhibitor with the sitagliptin and metformin? Dr. Nisar? Doctor? Yes. Dr. Vivekanand?
Dr. Parikh,
Yes,
being
yes.
a vascular surgeon, my contribution toward
Yes, sir.
Yes, yes, yes.
Yes, yes.
Yes.
Am I audible?
inadequate and
Yes, yes,
pretty
yes.
Yes, sir.
ancient.
Sorry.
Yes, sorry. Yes.
I'll let you take the lead. I'll contribute more during the
Thank you,
next
sir. Thank you, sir. Thank you. Thank you very much.
Yes, sir.
So I
I
think-
can hear now.
Yes.
Yes, sir. As you said, there was a good option to start SGLT2 inhibitor, but sir, initially she was actually, we were suspecting a focus. In fact, we were expecting a keto, but with the sitagliptin and metformin, she improved a lot. So in spite of changing the medicine, I continued with the same as she was showing a good response. That was a good option to control her body weight as well. So, and she was a female, so I considered to continue with the DPP inhibitor to avoid UTI and compliances.
Right. For fungal infection also.
Yes, correct.
That is very good. So actually, basal insulin is the best option, and there are very less chances of hypoglycemia.
Yes.
And even if there is hypoglycemia, it is on a very lower side. So
Yes, sir.
not
Yes,
life-threatening. So it is
Yes.
very good that you switched on from glimepiride to GLP.
Yes, DPP4. Yeah,
DPP4, sitagliptin.
Yes,
And
Yes,
metformin naturally based, it is the primary drug on
Yes.
which other drugs are to be added. So I
Yes.
think the way she has been, she controlled her blood glucose in a very short period. I hope that in future also, if there is no contraindication for urinary tract infection or fungal infection, then
we can add double. Yes, SGLT2 can
it is
be added.
better to add SGLT2 because there is so many, so many
Advantage.
trials, it has shown that it can reduce the albuminuria and
Correct.
CKD also. So it is one of the best drugs for that purpose also.
Yes, sir. I'll consider that.
Yes.
Sir. Thank you so much.
Can we, there are any questions in the chat box?
Yes, sir. Yes, sir. There are. Dr. Alpa?
Yes, sir. So should I start asking? I'll send it to you. Okay. So one of the question which has been asked is the patient is suffering from diabetes mellitus with microalbuminuria. So can we use canagliflozin?
Yes. If there is no contraindication for urinary tract infection or fungal infection, and
we can use.
Dr. Nisar said she is a
Yes.
lady, so there are chances of fungal infection. If we rule out, it is a very good drug to be used, because in so many studies it has been shown that canagliflozin can reduce the kidney progression also to a great extent, and can reduce microalbuminuria.
Yes, sir.
So another question by Dr. Balram Sharma is asking regarding how to manage brittle diabetes.
How to manage?
Brittle diabetes, he has written. And the role of OHA like metformin and PIO in type 1 diabetes.
I don't think in type 1 diabetes there is
Use
any
OAD.
indication. Yes.
Yes, sir.
Yes, Dr. Mohammed. Yes.
Yes, as you said, sir, in type 1, we are not, we don't think we can use OADs other than insulin.
Yes. So another question is regarding the brief note on the management of type 2 DM with the latest drugs which are available.
There are so many good OHA which has come in last 1 decade, and this DPP4 and this GLP-1, now even oral GLP-1 has also come, these injections. So I mean, they are really wonderful drugs. They do not cause hypoglycemia. They take care of your cardiovascular system. They also take care of kidney disease also. So they are, unless a patient has got very high blood glucose level, where you can use basal insulin also. But there are these molecules are to be used because they are much better. They are better than this sulfonylurea, because there are less incidences of hypoglycemia. Then there is a weight increase with sulfonylurea, which is not there with these drugs. So they are good drugs. I mean, even about 20, 30 years back, we were only thinking about the control of blood glucose, and then we started controlling weight and less incidence of hypoglycemia. But then in last 10, 15 years, we are thinking that the drug should reduce HbA1c, but also take care of your kidney, heart, and every other system also, retina and everything. So these drugs are really very good drugs. If there are no contraindications, then we must use these drugs, and they are good add-on drugs with sulfonylurea, with insulin, and with metformin. Even they have come GLP-1 and SGLT2 inhibitors have come on the top. You can use as a monotherapy SGLT2 or GLP-1 with metformin, even without metformin. So these are very good drugs, because you are free in your mind that they will not, when you start to a patient these drugs, you know that patient will not have hypoglycemia incidences. Because many times when we start a drug, we do not know that with how much doses the patient his blood sugar can be controlled. So that is one of the biggest advantage of these drugs, that they do not cause hypoglycemia. I can ask Dr. Mohammed that even with sitagliptin, but why a patient was having hypoglycemic attacks. But I think because she was on
she had an episode of skipping a meal, sir. She had an episode,
and because also she was on basal insulin, that can cause mild hypoglycemia. Right.
So there are more questions. Should we take it at the end, or should I continue with it?
Yes, you can take it in at the end of also.
Okay, sir.
Yes.
So by this, it's a privilege again. I'll introduce our second chairperson and the speaker for today's second session, which is on MROC in DFI. First, I'll share the screen, please. Chairperson for the second session is Dr. Vivekanand. He is a consultant in the field of vascular surgery at Sagar Hospital. He has a career in medicine spans around 19 years. He has done his specialist training in the vascular surgery and endovascular surgery. His areas of interest are in video-assisted thoracoscopic sympathectomy, subfacial endoscopic perforator surgery, endoscopic vein harvesting techniques, deep venous reconstructive surgeries, newer modalities of managing chronic venous insufficiency. He has presented endovenous laser ablation of varicose vein in Asian Vascular Society conference, which was held in Bangalore in the year of 2004, and many more achievements in his accolades. After this, I will introduce the second speaker. We'll be talking on MROC in DFI, Dr. Sanjay Sharma. He has 11 years of experience as a podiatric surgeon with the lowest number of amputation rates in DFU patients, as per the independent study done by the pharma giant. He holds a blend of qualification management, artificial intelligence, and health economics from Indian Institute of Management, Bangalore, Indian Institute of Science, Bangalore, and World Bank, respectively. He has been facilitated as a rising star in the Times Healthcare Achievers Award, which was instituted by the Times Group and Government of Karnataka in the year of 2019. In the year of 2022, he was awarded as the best podiatric surgeon in Karnataka in Times Group. Foot Square was also been awarded as the best podiatric clinic chain by the India Today Group in Jan 2020. By this, I will stop sharing this and I'll request Dr. Vivekanand to do the contact setting.
Good evening, ladies and gentlemen. Thank you for the introduction. Extremely old, but I think I didn't do justice in giving you the latest information. Anyway, we've been running a diabetic foot clinic for the past 20 years in Jain Hospital, one of the earliest centers to start off. And it is a privilege to be chairing the session along with Sanjay Sharma, who's done excellent work in the field of diabetic foot infections. Very good teacher and a very good practitioner. Diabetic foot infections, as and when they present to our doctors, is an extremely challenging condition for the treating doctors, whether it's the physician or the surgeon. It basically means that we as physicians and the counselors have failed in preventing this from happening. So there's a lot more work to be done in trying to prevent this from happening than having us to treat this condition. So there is a more responsible role for the physician as well as their counselors in preventing this from happening. I think we all know diabetic foot infections. Yeah, one, they have 30% have vascular insufficiency, around 60 to 70% of them have neuropathy and infections. Among these things, the only thing which can really be corrected is to some extent vascular insufficiency. If they have macrovascular disease, can be corrected with newer techniques. And infections, we can control it with a lot of modalities. But just thinking that by improving the blood circulation and starting the patient on appropriate antibiotic, we are going to achieve complete wound healing is a fallacy. So it needs an extremely holistic approach and extremely challenging for a vascular surgeon to go into diabetic foot care. I've realized that, it's easier to do vascular surgery or easier to do neurosurgery than doing diabetic foot surgery. It's extremely challenging, takes months to achieve a good foot salvage, and a lot of dedication from the treating surgeon or the physician, and truly a multidisciplinary team. But you must always have one person leading the team. Otherwise, the patient gets referred from one specialist to another specialist. And when running around, he ends up losing his toes or his foot. So we need more and more foot soldiers who will try and prevent it and treat it at an earlier stage. With this brief thing, I'd like to ask Sanjay to give his presentation, and then we can have a good discussion.
Thank you very much, sir. It's been a pleasure meeting you online. Also, we have, even though we are in Bangalore, we hardly have been able to catch up. And thank you, the Wockhardt team, for organizing this. As Dr. Vivekanand said, a diabetic foot ulcer or a diabetic foot infection is absolutely a team approach. Without a vascular surgeon,
we as podiatric surgeons cannot do anything, or even orthopedic surgeons or general surgeons wouldn't be able to do anything, including physiotherapists, orthotists, footwear makers. You name a stream that would be required in team where we are managing the diabetic foot ulcer. With this preamble, I'm going to share the screen. If you can just see if it is visible. Is the screen visible?
Yes.
Absolutely.
Yeah. So a quick roundup, just giving the Indian statistics. We all know that globally every 20 seconds, or even now it has been mentioned as 18 seconds, a limb is lost due to diabetes. We have about 70 million diabetics in India, 34 million with diabetic peripheral neuropathy or peripheral arterial disease, 6 million people with diabetic foot ulcers, and 50% of them are infected. They spend almost about 10.5 billion yearly in managing a diabetic foot ulcers. And we see about 1.3 million amputations yearly and 1 million mortality. If you look at the 70% mortality that has been published for every amputated patient. Not just this, when you're looking at mortality perspective, the diabetic foot amputee has the highest mortality just below the lung cancer. And a diabetic foot ulcer comes in the top 6 or top 8 mortality rates. With this kind of incidence and prevalence that we see in India and globally, it is high time that we spend enough awareness that needs to be created, not just amongst the patients, but also amongst the doctors on how and when to intervene. As Dr. Vivekanand mentioned, it is not just about a vascular surgery and treating with diabetic foot infections. So the key thing holds as Jain Hospital also has its own footwear manufacturing unit and footwear dispensing unit, biomechanics and offloading, and these components, and including physiotherapy, and these components play a very important role, which is usually missed out by the doctors. We keep on dressing the wound, but will not look at any offloading mechanisms. So that's something that we need to keep in mind before we, get aggressive on any surgical procedures or treating the infections. As I said earlier, 50% of the DFUs are infected. And infections are usually severe with high risk of mortality and morbidity, as we discussed earlier. 80% of the lower limb amputations in diabetic patients are preceded by a biofilm infected foot ulceration, and which leads to amputation, and these can be prevented. Studies have enough told that 80% of these amputations that happen due to diabetes can be prevented by an early intervention and an appropriate intervention. DFIs are potentially disastrous and rapidly progress to the deeper spaces and tissues. And mostly these infections are polymicrobial with gram-positive pathogens, mainly staph, and we also see Pseudomonas much, very rampant in the, at least in my clinics where I'm seeing the patients. Though MRSA is present in 10 to 32% of the diabetic infections and is associated with a higher rate of treatment failure, morbidity and hospitalization costs. It is said that for each ulcer, a patient in India spends about 1.32 lakhs as an average for it to heal. So the Staph aureus research has been done. The rates have gone up from 2016 to 2021. This is some statistics that have been published by ICMR. And there have been certain limitations that we are seeing in the existing anti-MRSA agents. It could be clindamycin or linezolid or tizofactin or any of them. They have a bacteriostatic activity. Some of them are only IV. We don't have oral medications where most of the patients would prefer, or it needs a hospitalization for a long term. So considering these things, where there are certain limitations with the existing drugs that we see, we're looking at overcoming these limitations through MROC and MROC-O, which has a rapid bactericidal activity than a bacteriostatic, and which has a broad spectrum activity against the MRSAs. And again, for the oral and intravenous formulations, both are available. There is no loading dose requirement and other things that we see there. And the studies have shown that it has a superior safety effect. So with this as the background of the MROC, I'm going to present one unique case. It is not a series of case studies. I've tried MROC in at least about 20 to 30 DFI cases in the last 1.5 years. The first line, obviously, being the other antibiotics, which is much economically viable. But when they fail in that, we switch over to the MROC. So this study was a 63-year-old male patient with type 2 diabetes mellitus for about 10 years, diagnosed for about 10 years. He had already had a TMA of the left foot. He presented with a diabetic foot ulcer on the right foot, including the right lateral malleolus. The sizes are mentioned there with purulent and odorous discharge and a fluffy wound bed associated with the Charcot deformity. It was stable when the Charcot deformity was there, but it was not an active Charcot, it was a stable Charcot. Post debridement, post the CNS of the tissue, Staph aureus and E. coli, which was sensitive to linzoid and piperacillin tazobacter.
Dr. Sanjay, we lost you. Dr. Alpa, if you can connect with him.
Yes, sir, I'm just.
Yeah. Yeah.
He is not picking up the call.
Probably he's unaware of the fact that he has been disconnected from the meeting.
Yes. He is not even on the panel right now.
Yeah, his network just gone. That's why he's out. Dr. Vivekanand, sorry. I mean, this is one of the first times then such things are happening. I think altogether, Dr. Nisar is not able to connect. Dr. Sanjay is not able to finish his presentation. We tried our level best to have all these technical snags in control, but many things are out of our hands. Sorry for the interruption, sir.
No. What we'll do is, we'll keep trying to get a perspective about the kind of cases like, what Sanjay just presented. There is an ulcer, there is a infection. Most of the ulcers over a period of time tend to get infected, and giving antibiotics and hoping that all the infection will go away in a matter of few days is wishful thinking. We've seen that, even in, let's look at, though it's old classification, even if it's Wagner grade 1 or grade 2, the average healing time is between 6 to 12 weeks. And the deeper the infection, the more it goes towards osteomyelitis. We're looking at 3 months to 5 months to heal the wound completely. So it's not that, just doing one good dressing, because we keep coming up with, use this ointment, this will get better. And you come up with a new molecule saying that use this, everything will be fine. Yes, all these things are supposed to help the wound per se as such. And just like what Sanjay said that, I have used your molecule quite a few times. Wonderful results, but we usually end up using it once all the things fail.
Correct, sir.
Maybe, we as the treating doctors need to start thinking of it after the first line fails before making the patient spend a lot of money and then come to this as a last resort. Maybe we should start using newer molecules a bit early, but again, we are worried a little bit about the resistance creeping in also. So use of the appropriate antibiotic at the right time and for the right duration of time is most important per se aspect, I think, with respect to diabetic foot infections. One is treating them with antibiotics, and using the right antibiotic, right dressing material and offloading, you can achieve a wound healing. But the problem is to prevent it from happening again, because more than 60% of these ulcers which have healed with the right treatment tend to recur because the underlying cause, is not addressed. So treating the infection is part of it, treating the biomechanics of it, that is treating the abnormal weight distribution, teaching them about gait training, telling them to start using either a walker or they need to use a walking stick so as to offload the weight is also important. The other thing I would like to, Dr. Parikh is there. So I'd like to remind the physicians and the diabetologists is once you have a diabetic foot infection, because it's basically a physician's patient, he refers the patient to the surgeon or to the vascular surgeon, but he has to remain in charge. We as surgeons, we think that, okay, I have done a good debridement. I put him on the right antibiotic. I'm using the right kind of dressing, but the wound is just not healing. The wound is not healing because no doctors contribute to wound healing. The wound healing is done by the body. No drugs cause wound healing. The wound healing is done by the body. And the wound healing takes place only when there is absolute optimization of the biomechanical parameters or the endocrinal parameters by the body. We see many of these patients have, like the previous speaker mentioned, microalbuminuria. They have albumin deficiency. They have edema. And we give our antibiotics and the carrier molecule invariably is the albumin. So we are telling that we are giving the antibiotics, but the antibiotic is not reaching the infected site in adequate concentration. So the physician, though I'm a surgeon, I'd like the physician to get more actively involved, and HbA1c needs to be brought under control. C-reactive, reactive proteins need to be brought under control. All these things need to be holistically brought together. As surgeons, we are unable to do all that because I hate to say that we are more procedure oriented and dressing oriented or drug oriented. And if you ask me, just like Dr. Parikh asked me a question about glycemic management, I'm unaware. So I need the help of the physician or whoever is treating the diabetes, because without that, without optimizing the patient per se as such, no drugs can heal the wound. And one request to you guys from Wockhardt is, if you can somehow reduce the cost of this wonderful drug, it really works well. If you can reduce the cost, you can benefit a lot more patients. I know, you might have spent a lot of money in researching this molecule, but for the society per se as such, you'll be helping a lot of people save their toes or save their legs by, if possible, reducing it. Sanjay is back. Sanjay, back to you, Sanjay.
No, sorry for everyone. There was an internet down here, so I had to wait for it to get connected back. Is everybody able to listen?
Absolutely.
Sir, we could listen to you from the start of that case. You were just starting the case and the internet snagged. So
okay.
You can start from there, sir.
So I think the case was the 63-year-old male patient with type 2 diabetes. Sorry, 1 second. Okay. Type 2 diabetes with a transmetatarsal amputation of the left foot.
Shared your, sir, sorry to interrupt you, sir. You haven't shared your screen, sir. We cannot see your screen.
1 second.
Yeah.
1 second. Now?
Yes, sir. We can see your screen. Go ahead, sir.
Okay. So, sorry if I'm repeating this. It was a 63-year-old male patient with type 2 diabetes, had a transmetatarsal amputation of the left foot, presented with an ulcer on the right foot. The sizes are mentioned there. It was a stable Charcot foot with purulent discharge, and when we did the culture and sensitivity of the tissue, what we got was the Staph aureus and E. coli sensitive to linezolid and piperacillin tazobactam. What we did was the wound was debrided, and as per the culture and sensitivity report, the patient was started on piperacillin tazobactam for TID for 7 days, and all because the infection didn't significantly reduce, and the patient was not keen on getting admitted. We continued with linezolid for 7 more days, and topical Tussings was applied. Wax was also applied for 1 week. The wound size was decreasing, but the cavity was significantly there, almost about 10 centimeters from the lateral to the medial aspect was there. And the local condition of the wound remained infected. There was a decrease in the discharge, but the purulent discharge continued and it was odorous. And considering all these considerations, MROC OBD was started. And what we did was a bit of an experiment. We always used stimulant beads in the ulcers with various antibiotics instilled into it. So, but this time I tried out the MROC MROC on the stimulant beads. Even though many of them said that this is a 100 ml IV, the dosage might not be significant and all those things. I said, like, what's the harm in trying? So it was put on the wound and then filled. The whole cavity was filled with stimulant and was in situ for about 15 days. This combination therapy yielded a complete reduction of the infection and growth of the granulation tissue. And this is how we could see the wound when he presented with the cavity that you could see there from the lateral aspect to the medial aspect. And VAC was applied, and we could see on day 20 the stimulant beads are still in situ. We kept on adding the stimulant beads. It's not just once it was instilled and left like that. So as and when we could feel the cavity there, we kept on adding the stimulant beads, which was instilled with MROC, and we could see the almost complete healing in day 45. And this is about a year and a half old, and the patient wound is completely healed, and he's walking on both his legs. And we did prevent an amputation using this combination method of IV antibiotics, oral antibiotics, and stimulant beads laced with MROC placed on this. This is some of the pictures from our from our software where how we track the progress on this. So this is a case study. Even though I have used it in multiple cases, I thought this was pretty interesting. We had where we had a combination of therapy. So with this, I end my single case study, and happy to answer any questions.
Thank you, Sanjay. When you were briefly off, I was discussing about how long it takes for a usual diabetic foot wound to heal. So I was telling them, 4 weeks, 6 weeks, 2 months, 3 months, sometimes going on to 4 to 6 months as such. So we need to be, diabetic foot surgery or healing diabetic foot infections is a project. A person must have a passion for taking care of the wounds. It's not just dressings, and it's just not any kind of devices. You need to spend time, and the same person should be looking at the wound to make sure it doesn't track along the tendons. And the result, what you see is like what he said, it took around 45 days or 60 days to finally heal it. And again, like I was telling, it is not just healing that wound. He already has Charcot's foot, and it is our duty to make sure that he is offloaded appropriately and to prevent this wound from recurring again. Sanjay, any further thoughts you'd like to add? I also requested the Wockhardt people to reduce the cost of this.
Absolutely, sir. Absolutely. That is the major impediment in prescribing it to multiple cases, especially the MRSA cases that we see. And as you rightly said, he had a Charcot foot. Diagnosing a Charcot foot itself is something that we need to be pretty early on. We should not confuse it to cellulitis or any other inflammation, swelling, or anything. So that has to be done very early on and offloaded. This patient was on an aircast boot for almost about 6 months. And thankfully, he was compliant, and we were able to save his foot. If the patient was not compliant, it was difficult to save his.
I'd also like to tell the physicians, Dr. Parikh and Mohammad Nisar, saying that, treating diabetic foot infections is an extremely expensive affair, though it's a simple, though it looks like a simple ulcer which is infected. It takes a long time, and if you really add up the kind of procedure or the amount of time spent both by the patient as well as the relatives in bringing him out regular intervals for addressing change, inspecting, controlling all the other biomedical parameters. It's a very expensive, it's as expensive as treating malignancy. We seem to overlook that. So that is why the role of physician becomes very, very important, because if you optimize the patient faster, try and control the microalbuminuria, prevent albumin leakage, it will help us in healing the wound faster. And that is why, it truly is a multidisciplinary approach. And we need literally hundreds and thousands of foot surgeons, dedicated foot surgeons in this country. Otherwise, we are looking at a horrible situation where we have young people losing their legs. Whether it's young or old, nobody should lose their leg. And few people, all of you need to identify one surgeon and nurture him and make sure that, he does a good job and hold people accountable. You have to have a look at the wounds. It's not just enough that, you just refer the case and that's it, only look after glycemic control. We urge you to take responsibility for your patients and keep interacting with the physicians, because with the treating surgeon also, because we need your help, you need our help, and we both of us need the patient and the relatives' help for it.
Very rightly said, Dr. Vivekanand. I think this is the responsibility falls on the physician to refer the patient at the right time to the surgeon, because most of the time I have seen the physicians are trying to treat the patient, and when the things have gone beyond their them, then they refer him to the surgeon. The most important thing for us is the prevention of diabetic foot. Prevention is much more important than the treatment. You must aware the patient about the prevention of diabetic, foot problems, because every time clean your foot, don't use the right shoes, then wash every day and see in the glass. There is something in they should also find out something not here, this damage the foot in the shoe also. So it is very important. And then second thing, that the optimal control of blood glucose level lies on the physician. So there are three things: prevention of diabetic foot, then timely referring to the surgeon, diabetic foot surgeon, and then the keeping during that time glycemic optimal glycemic control of the patient. So these are the part on the physician's responsibility on these three things.
Yes.
Then, because as Dr. Sanjay said, it is a teamwork. So physician is also a part of the team of diabetic foot problem.
Definitely, sir. Definitely.
And then the patient has to be put on insulin and other things also. The right medicines to be used. That will be done by physician rather than a surgeon.
Yes, sir. Correct, sir. Correct. It's a it's a clubbed procedure. Actually, the wound healing is done by a physician as well as a surgeon. Actually, as the sir said, all the biochemical parameters and the wound healing process should be done by better glycemic control from the efficient part.
Only one area where I differ with Dr. Parikh. Sorry to say that. I said you need to refer. You said you need to refer it to a surgeon. Please refer it to a surgeon who's dedicated to treating diabetic foot.
No, but as you said, the number of foot surgeons is less in India.
No, sir.
You have to train surgeons for this diabetic foot surgery, vascular surgery. I know I had a surgeon, Dr. Pathak, who was the general surgeon, but he used to do Dr. Daima. They were using, they were really dedicated, doing a dedicated surgery for diabetic foot surgery. So, even general surgeons, even those who are interested in it, we have to train, because we have got a very less number of foot vascular surgeons or foot surgeons in India.
You don't need a vascular surgeon, sir. I am in this because of my passion for treating diabetic foot infections. We need good surgeons, good orthopedics who are passionate about treating diabetic foots, not a famous laparoscopic surgeon who's got fantastic practice. He might not be interested in this, doing a toe amputation or treating diabetic foot infections. He just relegates it to the nurse and then says, do the dressing, do this, do that. So what I meant was any surgeon who is passionate about saving feet and saving toes is most important. That's all.
And also we need a dedicated nursing staff also, those who are trained in this diabetic foot surgery or taking care of diabetic foot patients. So we need a dedicated nursing staff also, because it is a very important dressing and other things under the supervision of a surgeon has to be done by the nursing staff. But I know one of the foot surgeon, Dr. Daima, he used to do himself all these dressing and everything, looking for the patient's foot. He was doing himself every time.
I think since we've initiated this topic of diabetic foot infections with the physicians, I think Wockhardt should take the lead in, starting more about the basics of it, how to identify a foot at risk, and preventing it from going into ulceration, and make it a series. And I'm sure Sanjay will be more than happy to share the preventive aspects of diabetic foot infection treatment, early detection and treatment, because learning about diabetic foot infections in one lecture is just not possible. We spend decades and we still are at a loss to find out what the hell is happening. So, maybe initiate a program, and then it's a continuous process, and all of us should put in our effort. Sanket, anything to add?
I think, sir, rightly said. We started with talking about how to manage glycemia in a patient, and then we moved to diabetic foot infections and ulcers around it. And you rightly said, it's not a one-man effort. It's an army effort. It has to be, all together as a team to get the things moving in the right direction. And someone needs to take that leadership, that stand, to make sure that, there would be less to and fro, there would be lesser time, there would be more intensive way of managing it. And lastly, you mentioned about the multiple antibiotics that you try to reach to the final stage, and then you get the right antibiotic in. So, maybe as the experience goes, we would have MROG being prescribed a little earlier than what we are doing it today. And lastly, sir, you mentioned about the cost of medicine. Well, yes, that's something which always remains in the back of our head. We doctors will always want our patients to have affordable medicines. Maybe once, we from the business end, if I have to speak, once the business flows in the right direction, the part of patient support programs and the cost of reducing the cost of the medicine will always come in place. So we wait for the time and we move towards the right direction. And I think having such kind of expert speakers today, Dr. Sanjay, Dr. Nisar sir, who presented such beautiful cases along with expertise of our moderators, Dr. Vivekanand and Dr. Parikh sir, I think that made this program something really beautiful and engaging with an interactive wisdom that was shared today. Now I'll request our marketing head, Priyanka, for giving our vote of thanks. Over to you, Priyanka.
Thank you so much, Dr. Sanket. First of all, I would like to say today we had a little technical glitches. So the program started a little late. So apologies for that. But nonetheless, we covered up with the wonderful discussion that we had with both our chairperson and both the faculties. So first of all, I want to extend my heartfelt thanks to Dr. K.K. Parikh and Dr. Vivekanand, who have been very gracious in sharing the session, and they shared valuable insights. Dr. Nisar, Chairman, Dr. Sanjay, they shared their wonderful cases. And I think the best form of learning can be in form of experience sharing, which they did. So thank you so much, Dr. Nisar, Dr. Sanjay, for having us with you over here and sharing your cases. And this entire event has been managed and taken care of by our medical team, headed by Dr. Sanket. Along with him, we have Dr. Alpa, Dr. Kunal, who are helping us in the medical insights day in, day out. And let me also take the opportunity to say thank you to our president, Mr. Amrit Medekar sir, and Mr. Vishnu sir, who is our guiding light in all the events that we do. Last but not the least, my field team, who is at the forefront, making all these events possible, because they are the ones who approach all the faculties, delegates, and make these programs so successful. So thank you so much, everyone. And I'll also like to take a moment to just remind few of the brands that we have, because this session has been powered by few of our pillar brands, starting with Bolsulin and Glimadate, who have completed 20 years in this year, and both have been pathbreaker in their own way. Apart from that, we also have MROC, who's a new kid on the block, but it has been helping a lot of patients of diabetic foot infection to overcome the issues. So that was all about today's L20 Summit, and we'll meet again next month with a new session with new faculty and new topics of discussion. So thank you so much. Take care and good night. Thank you.
Thank you so much.